Hi, this is Alex Cohn from the D. McGee Eye Institute. This is a case that Vinay Shah and I did recently of a young man with homocystinuria and a severely sublux lens. You can see here that there's about 180 degrees of zonular weakness. We began the case by putting air into the anterior chamber. We next placed trypan blue to stain the anterior lens capsule. Next, we placed a dispersive viscoelastic in the eye to displace the air and the trypan blue. A clear corneal incision was made. And then a capsulorhexis was initiated with a pre-bent cystotome. You want to try and center this capsulorhexis where the final lens position will rest. And this side is very difficult given the zonular laxity as well as the fact that only a part of the lens can be seen. So what we did here was just kind of stop the rhexis to the edge of the iris. We were planning to place an Ahmed segment, so a peritomy was made temporally. And then this long CTC 6L needle was passed with a 9-0 proline attached through the sclera underneath the iris, around the lens, and then up through the cornea. This is a double arm suture, and you can see that here's the second arm going in a similar fashion again through the sclera, avoiding the lens, underneath the iris, and then out through the cornea. It doesn't really matter where you come out through the cornea, you just want to bring it out somewhere away from the visual axis. Can then cut off one of these needles and then go back in with a Kugelin hook and pull out the suture in its entirety. You still have one suture that's attached to a needle. The Ahmed segment is then brought into position and the 9-0 proline is threaded through that central eyelet. The Ahmed segment is now set up to be placed in the eye. This requires about a 2.8 millimeter incision, and you can just place the segment into the eye. And then if you remember, we don't have a complete capsulorhexis here, so this was kind of tricky trying to fit this segment through this small little rhexis without ruining the capsule. So we did this with a combination of Kugelin hook, and these are the Duet micro forceps. And I was able to just kind of get this Ahmed segment into the lens capsule and then bring that trailing segment underneath the edge of the rhexis. You notice that the segment is in no way oriented where it needs to go. It actually needs to go to the upper part of the frame here to bring that lens over into position. So I then use these Duet forceps to really rotate this segment into the correct position. And this lens was relatively soft, so it was able to move pretty easily. Once the segment was in the correct position, I was able to then go back in and bring out a loop of this other arm of the 9-0 proline and use a Siepser internal sliding knot to tie this down. And you'll see here that when the knot is cinched tight, it brings the entire lens over to its more anatomical position. And you see that the Ahmed segment also comes over appropriately, and the whole lens now is shifting over to the upper part of the screen there. And you can pull on the piece of suture that's outside of the eye, and you can see that there's not really much room left to move the lens over. So then we just complete the Siepser internal knot with another few throws, and then place more viscoelastic in the eye. As you remember, we have to complete the capsulorhexis here. This was a bit tricky because this capsule was not behaving like a senile lens capsule and it kept wanting to run out. I got into a little bit of trouble here with the lens capsule wanting to go peripheral and had to use a little rescue technique to complete the rhexis. You see here pulling towards the center and the capsule snaps and we complete the rhexis. It ends up being round and continuous. The lens was then hydrated gently, and this was a soft lens in a young person, so this was able to just be remove with the irrigation aspiration handpiece. The lens material underneath the Ahmed segment was a little bit tough to remove, so a bimanual tip was brought into place, and this really helped remove that subincisional cortical material that's trapped by the Ahmed segment. Provisc was then placed in the eye to inflate the capsular bag. And you see the rhexis is kind of large, but it is continuous and round. The 9-0 Prolene sutures are then cut with duet scissors inside the eye and close to that eyelet. And then a 3-piece lens is placed in the capsular bag. This was rotated in the correct position, and everything seemed very stable here. The viscoelastic was then removed from the eye, and I chose to place a few 10-0 nylon sutures to close that large wound. At the end of the case, everything looked well centered and stable. This is Alex Cohn from the DME Guide Studio.